Thank you, Sanjeev. Thank you for all the team for your very warm welcome in Stanford, where I'm also very honored to come. The subject is about the most complex arrhythmia, atrial and ventricular fibrillation. You know, they are the most complex. When you said complex, is related to all other arrhythmia where we have a single thing to find. This is an orchestra of many different activities together, and is why they are considered as the most complex. And they are devastating because for AFib, it's an epidemic arrhythmia, 2% of people, the cause of 20% of embolic stroke, and it increased dementia and heart failure. And VF is the main mechanism of sudden cardiac death, which is my full 100% time topic. I would say to start to do like Sanjeev said, it's the ultimate big hurdle. They are considered AFib and VF has a multiple chaotic wave. And when you look at the description of all these different activity since 1 century ago, they look for, if you want to do catheter ablation, they look very intimidating because you see something moving everywhere. We said, how can we do something for that? The epidemiology of AFib in the 21st century, it's in this paper from the American Heart Association. Donc it's terrible. There will be a huge number of all these patients, up to 2% of the population. And we know that 1/3 of AFib are asymptomatic. Donc this is a problem because they are at risk, but they could not be identified. AFib is considered as a multifactorial arrhythmia, intertwined with a common risk factor, hypertension, diabetes, etc., and all that leading with age to degenerative process. And the prevention program are missing. To discuss after discussion with Sanjeev, this is a brief history of catheter ablation of arrhythmia. First ablation was arrhythmia surgery for VT, ventricular tachycardia, with an aneurysm surgery, 59. And when I was a young fellow, we were educated mainly with you do Holter recording, you count how much ectopy, and then you give antiarrhythmic drugs, and so on. We have a few patients for arrhythmia surgery, and at this time came implantable defibrillator and coronary angioplasty. A lot of revolution came, and particularly defibrillator allowed to protect patients with sudden cardiac death. And in '82, when I was just a new chef de clinic, we started DC shock ablation. The first DC shock ablation, this is a movie from Frankenstein. It was considered as something crazy because they said they put a bomb inside the heart, they will kill everybody. Well, and the first one was by serendipity. Look, the story is funny because a patient was explored for VT. He had a ventricular arrhythmia. The nurse delivered a shock, and there was a short bypass to the electrical wire inside on the his bundle, and the patient was defibrillated, but by electricity, his bundle was cut. It was the first AV node ablation. And by looking at this, Shainman and also Gallagher work on that in animals, and they developed the first DC ablation of his bundle AV node. Donc the main indication was supraventricular tachycardia. You cannot control them. You cut his bundle and you put a pacemaker. But it was beginning. And VT was shown in '83 by Hartler, Fontaine and Frank for VT2. First WPW was Breitart. We work in 85. I was 31, 32, something like that. And we work on WPW, what Sanjeev said. Moradi was working on anatomical methods, said the pathway is something here, I will deliver a shock. Gillette, Cosio, and we also work in AVNRT early that. And I will say it's a hard school. Sorry, because people say, okay, with DC shock, you have just to approach at 3 centimeters, boom, and you deliver. It's not true at all. In fact, when DC shock, you have only one shot cell, because we have to be sure it's there, and you deliver one shock, you make anesthesia. And I said it was hard school because we have a single attempt, and we have to be sure it will be there. And I remember for WPW, full days, we look at what is the accessory pathway. You have the two potential at the junction atrial and ventricular. We have a tiny potential, and we spent a lot of time to be sure we are at the right spot. Accessory pathway is 1 millimeter wide. Donc all this stuff was, can we prove it's non-atrial? Can we prove it's non-ventricular? If it's non-A, non-V, it's the accessory pathway. Donc we have a lot of knowledge coming from this hard school, and the catheter were non-steerable. Donc it was full day mapping, but we learned a lot. And when radiofrequency came, people said this is a full revolution, but all the method was already known from the hard school of DC shock ablation. And then RF come into a clearly safer and high success rate. And based on that, Doc Zibe said, this is a WPW, this is a bison, and they are endangered species, because we know that all this simple arrhythmia will now be accessible to curative treatment. And it is what is happening. The revolution came by a lot of EP mapping before, and the perfect energy coming out with steerable catheter. At this time, the last big hurdle was considered to be AFib in the world of Wellens, because the treatment had a very low efficacy. All this sotalol, flecainide, quinidine, etc., amiodarone. At this time, after 1 year using radiofrequency energy and 10 years or 5 years working on DC shock, we were very impressed by RF. And I remember we have a finish on Friday, DC shock ablation. On Monday, we received the first catheter, and it was very simple because the catheter was fine. And after 1 year on that, personally, I saw, okay, it's finished. I agree, it's an endangered species. There will be nothing to learn. We will ablate all accessory pathway, all AVNRT, all attack. And after 1 year, said, what else? I mean, the knowledge was enough, and we were sure that we will spend our time on the lab. And I decided to move to AFib, to the last big hurdle. At this time, it was a maze procedure by Jim Cox. It was efficacy, it was efficient, but it was a very aggressive labyrinth. You cut in many parts your right and left atrium to control the rhythm. And there was also by Giraudon a different pathway where sinus node is connected to the AV node. Now, when you look at the paper, Lewis, Moe, Alessi, Boino, Halife, there was a lot of animal or a lot of modeling, Moe, for example, and all these papers talk about multiple entry. But when we look at the human data, at this time we said, okay, that is very few things. We talk about this multiple wavelet here, but what is happening in man? And the catheter were very crude. We had a decapolar catheter, and necessity is a mother of invention. I know in Stanford, you know this word. And we decided to create a catheter. And it was a 2 years discussion to get, with the main company, to get a very simple catheter, 14 pole, for mapping. So we can map 14 spots at the same time, and for ablation. This was the step. And we have this catheter, and we start to map multiple sites in AFib. We see some spots were moving every time, but some spots were fixed. The signal were the same. So we had a lot of knowledge coming from this mapping in all patients with AFib, thanks to this multipolar catheter. And we try also to understand some consistency in what we were looking for. And in parallel, we also work in cadaver, just to obtain the mold of the atria. And we had mold small like that, a young woman or things like that with a different shape. So we were trying to understand what would be the field of this method. And the first paper came. We have 3 patients here in this paper where we found that AFib was organized everywhere except in some spot. So in contrast to the theoretical that multiple wavelet everywhere, we had something what was relatively localized in complexity and simple outside. Look, this was a 36 woman paroxysmal AF, and we found this this was a tracing that Shainman also came and confirmed as AFib. And we had a rapid activity in a small spot. Rapid 140 is 400 beats per minute at this spot, 400 beats. Everything else was slower. It was in the superior vena cava. We obliged there, he stopped. And this man was with lung disease. Everything was simple, except in the carbotricuspid CS region, where we had this complexity. And we obliged this stop. So we have a 2 focal. And we conclude that AFib can be linked to focal mechanisms that can be treated by catheter ablation. Then we had, thanks to this catheter, we had a boat captain referred for AV node ablation. He cannot be anticoagulated because he could not have this boat. So he said, I'm ready to do what you propose. And we proposed to do the first linear ablation. Believe me, it happened exactly like that. We did 14 applications here. We did 14 applications here. And the next one was there, just to close the right atrium. And the miracle was there. When we finished the last application, AFib stopped. We were lucky, because when it was in the right ventricular atrium, and then we have done 45 more patients in 96. It was not working well in the right atrium. It was working better in the left atrium. And when we were doing this ablation with this catheter in the left atrium, we had some termination and we had some reinitiation. And this is where the story starts. So we said, okay, it's restart, but where is it restart? With 14 pole, you can move 2 or 3 times. And if you have a 3 or 4 opportunity of mapping, you will have an ID. And we found the first some crista terminalis here, initiation, and pulmonary veins. And we had a fantastic tracing, like this one where we had a spike isolate. There was nothing, a spike here conducted, etc. Donc, we conclude that a significant number of these patients had something in the pulmonary veins, and also that it may act as during AF, etc. Then with Pierre, we had some more patients, and the big step was there. The big step was to have a patient who had only 1 episode, donc Monday or Friday, and how to get this AFib with a catheter inside the heart. And it was really hard work, obtaining and mapping a random initiation. Donc we put several catheters. Just if you have one opportunity of mapping, we have enough antenna to see where it's coming. We use drugs to facilitate. We repeat the cardioversion, etc., etc. Donc it was more than 10 hours, but with the patient willing to do that because he understands that what we are looking for. And we have really worked on this window. This is the ectopic wave coming on the T wave, and we look what is here in this 200 millisecond mapping. What is the source of AFib? And after 4 years, donc we were also 45 patients. We found that pulmonary vein was the main source of activity. What you see here it corresponded to a burst of 300 beats per minute from inside the vein. It was not at the orifice of the vein. It was inside the vein, 2, 3, 4 centimeters. It was in the lungs. Donc this was a surprise. But we know now that the pulmonary veins can have the myocardial muscle entering into the vein. And we have striated myocardial. We have some extension of the heart inside the vein. And because of the success of ablation by burning these foci, the conclusion was multiple atrial waves are not the cause of AFib, but the consequence. They are secondary to pulmonary vein activity. And then we have a fantastic things like we ablate, the patient is in AFib. And every time we isolate one vein, the AFib slow down. We burn there and the AFib slow down. We burn another vein, it still slow down. Donc clearly that we have indirect evidence that the vein were firing at different times and each isolation, prolonged cycle length, kill one of the driver of air. And we also have that. You see the patient is in sinus rhythm here, but we have isolated the vein and there is an island of AFib 330 beats per minute confined here. So this was extraordinary. We then developed these two catheters, well known in electrophysiology, this pulmonary vein mapping and this one, just to still continue to do mapping. And Pierre Jace particularly invests his time to show that irrigated tip were more efficacious for linear lesions, and now everybody are doing catheter like that. And then, as you know, for the next 10 years, we had a huge development of multiple technology, helpful for AFib, but helpful for all the arrhythmia. The market of AFib is so huge that people develop this catheter for that, and they are applicable. Catheter navigation was a big stuff, contact sensing, and we have now many different cryo, laser, ultrasound, multi-electrode RF, and electroporation coming. So this was an explosion of case, and now we have about probably 700,000 or 800,000 every year, and this increasing like that because the market is huge. Now the consensus is we have to isolate the vein, the main driver, the main triggers, and this is a cornerstone. The success are very good for paroxysmal AF, 85% success. But now we have known that it's coming from there. We don't need to remap. We know it's there, and different techniques like cryo become anatomical. We don't need to do the mapping. We have done that before. The issue now is how to treat long-lasting, more than 1 week or more than 1 year AFib. And the success of PVI is only 50%, because PVI are probably one cause, but the rest of the atrium also. And there is two different techniques, PVI plus drivers. Donc this is what we call a source, extrapulmonary vein source of AFib, or PV lines, which are to do some compartmentalization of the left atrium. There are some issues in defining what is a driver that we can discuss. And for many time, we did different works with the group of Sanjeev, trying to understand how we can identify these drivers. We can discuss this point later. But when we do PV plus drivers, we had a very convincing result. You do your PV, you add 1 or 2 drivers, AFib stop. You see an AFib of 10 months continuously that stop, you are convinced. You said, okay, this is evidence that we have controlled that. And you can do that with 28 minutes, 30 minutes of RF. This is not so aggressive. Unfortunately, it was very convincing. We terminate 80% of AFib. But then the patient coming. He was coming back with a new type of arrhythmia named atrial tachycardia. And we always come back to what we have burned, and it has always reconducted at some part of the lines. So this was a bit discouraging. What we do was very nice acutely, but we had a high rate of recovery. And we have done that for 10 years. And in fact, we have to do a second ablation. We have to do another, sometimes a third one. The gap was in the continuity of the line, or it can be in the depth. In the 5 millimeter thicker atrium, it was sometimes on the other side on the epicardium. And because we can terminate most of the AFib, I thought, okay, we have something that is, we know that is true. We have some focal here, we have some focal in the atrium, and we show every time this slide, the limitation in persistent AF ablation are maybe more associated with inadequate ablation than with inadequate mapping. And the current strategy are this one. I don't know if we expand, but there is a new techniques now to ablate the drivers with the endpoint of AF termination. But when we do PV and lines and anatomical ablation, we have less AF termination. But if we have lines which are complete, again, the quality of ablation, we have a similar success rate. There are donc these 2 different methods are probably 2 options. I don't know if one is better than the other one. What we are doing now is this one, which looks better than the other one, but I'm not completely sure about that. Now, many studies underway. If we do early intervention, early ablation, that means you do not wait 10 years of AF, you reduce the incidence of stroke, so hospitalization. If you do early ablation, you also improve the burden, and you have different paper in the New England about that, early rhythm control therapy. In heart failure, it seems that it's clearly we increase survival of these patients. The paper are here, Narouche and Son, and you improve and you reduce the arrhythmia burden if it's come back. And this is also interesting. It's a paper by Andrade this year. When you do early ablation, you will impact the disease progression. That means if you ablate early, the number of patients moving to persistent AFib are much lesser than if you waited five years. Early intervention, reduction in disease progression, improvement of heart failure. And in terms of prevention, we know also different things. If we control the cofactor, the comorbidity factor, you decrease the remodeling, you decrease the deterioration of heart function. Sustained weight loss is also a risk factor that you can modify, and physical activity. There is some hope that prevention will also help the constitution of the AFib substrate. Future study. We have to demonstrate the full benefit in stroke, hemodynamic, the risk of dementia, the life, and the impact of early intervention. And of course, people doing some ablation are expecting better too. And this is a slide that is true for many different technology in medical application also. It takes 20 or 30 years to get the plateau. I think we are here. but we have still some progress until we'll be comfortable to do that. So if you consider that it's 30 years to get the plateau, like angioplasty, like surgery, etc., we have still some years to see, because we see this improvement with electroporation. Now the question of prevention of substrate constitution, this is sure. If you do reduction of this factor, you also do some prevention of coronary artery disease and all this heart failure. Now, I was thinking, in the pulmonary veins, there is some special cells. They have the action potential. This is Stanley Natal slide. They are special. I said, okay, if you have a medication that can block the pulmonary vein, should we need to do ablation? And in fact, the question would be, accessory pathway now is like the bison. You have to eliminate the accessory pathway. If your son has an accessory pathway, you will give flecainide for 30 years, or you will set ablation. And the question will be, even if we have a drugs to prevent remodeling or PV fibrin, the question will be whether we have to take every day or to treat the substrate wound with a small risk, of course, of intervention. Now, the ultimate frontier, ventricular fibrillation. I will say this is a spectrum of disease. AFib looks uniform. Maybe it's not true, but it seems to be about the same, PV, paroxysmal or persistent. But VF is more complex. Now the tissue is thicker, we have a bigger mass, we have a transmurality, we have a three-dimension. And I will describe here a lot of different substrate that looks to be exotic. Maybe in when you see that, he said, okay, this is it. But I think the spectrum is a different subset. And once we will know the different subset, we can do some preventive specific, some genetic specific to this subset. Look, we don't have 1,000 of these patients, but we have maybe 200 or 300 very well mapped, and they look different in some part. We have to do a deciphering of all an inventory of all these different scenarios, and then we will advance on that. VF. VF is interesting in contrast to VT, because this ventricular fibrillation is the main arrhythmia in young people less than 40, and in people with structurally normal heart. They do not have VT, they have a VF. When you look, the biggest part of sudden cardiac death, they have infarction, cardiomyopathy, donc they have an altered substrate, and they have more VT. Now, this is a spectrum that we will look about, and you know, sudden death is 10% of adult mortality in the world. The fundamental problem and the paradox is, we have the treatment of patients with sudden death. We do ICD, it works perfectly, ablation, drugs. But we don't have, we don't know which patient we have to protect. Okay, we will not expand on that, but clearly, all the objectives that what we are doing is to do risk prediction and prevention by genotyping, by structural imaging, by electrical phenotyping. Which patient here will die? Now, mechanism and ablation, we will discuss classically the trigger, that means the spark of VF, and then the two different subsets, the substrate in structural heart disease, the substrate in structurally normal heart. Trigger. Some people die simply because they have a small focus, very aggressive, that is rapid enough to create like pulmonary vein in AF, that would create to kill them. So this is special because the trigger by definition is random. Donc, in terms of prediction, we have to say, okay, how can I find something that is ephemeral, short-living? And for people here in practice, all PVC associated with syncope or which happen in catecholamine occurrence are probably something suspicious. Short coupling R1T, polymorphing more than 2, repetitive are also sign of suspicious where we have to do to be aggressive in terms of screening. There are two big groups of triggers in normal heart and abnormal heart with short coupling ectopy. But you see here what we call R1T in the past, and Purkinje cells, which is only 2% of the myocardial mass, are the major source of this VF. In this lady who died on the Holter here, we had the ectopy, it starts here and she disappeared. And 10% of this VF are from the myocardium. What is important is in a hospital is to get the 12 lead. If you get this ectopy, you don't say that, okay, this is a nice telemetric recording. We need to have the 12 lead, and then we have the picture. We know exactly where to go if one day we have to do that. This is trivial, but this is the minimum we can do. Purkinje particularly are implicated in nearly all channelopathy, but we don't have so much knowledge on that. Early repolarization, MEPPC, CPVT, long QT, short QT are all short coupling. Donc, we have idiopathic VF induced by these triggers in a group of patients who die simply because focus has started. And in ischemia, we had a discussion before with one of you. In ischemia, we have the same thing. When a patient had ischemic insult, sometimes 1 to 2 weeks later, there will be, due to ischemia, some change in the Purkinje. The Purkinje are superficial. That means even if you have an infarct here, it's superficial, and they are supposed to take some oxygen from the blood. I'm not sure it's true, but possibly. And therefore, they survive. The myocardium can be destroyed. They survive, but they have the behavior that is changed. Now, all this VF happening acutely, but rather 1 to 2 weeks after a PTCA or after some, come from the borderline, from the ischemic region. This is sure. So we have 2 big groups on Purkinje triggers in this condition. And we have less knowledge on what is happening in dilated cardiomyopathy in terms of triggering. In hypertrophic cardiomyopathy, simply because the chance to record are lesser than in intensive care post-myocardial infarction. Well, this is one of these 3 patients, 19 years, 36, 47. You see they have a short coupling here. They are narrow. Narrow is what we call the fascicular. Fascicular is a Purkinje system. And this is the mechanism that we can discuss where there is some notion of criticality. It's slightly an underestimated cause of death in the young. We are doing a study with 500 people followed for 20 years, and it seems that we have more and more of these patients discovered with a long-term following of this patient. The key issue is how can we predict something that is happening Monday, 10 o'clock, and never seen before. And often they have ectopy for few hours, for 1-2 days, and then off. It's on-off, and this is very puzzling in terms of prediction too. This is one of the patients from Tahiti we have seen some weeks ago. You see this beat here. And not only the first beat, but the second and the third one are Purkinje. So we start from the Purkinje, and we suppose that then it turns in 2 or 3 loops in the Purkinje, and you will admit easily that this network, this web, is perfect to have starting, but also to have maintaining, because it's the perfect setup. In this patient, we have a polymorphic VT. But the big difference with a myocardial polymorphic VT is each of the initial beats are preceded by Purkinje. So we have things that are due to a tissue with only 10% of the mass. So it makes a big difference because Purkinje and myocardium have completely different genetic and molecular characteristics. And this is by far the tissue we don't well. We have tried in this patient with a sudden cardiac death due to this short couple ectopy. We have done some pharmacological tests. It has been published a few days ago. And we have used ajmalin. Ajmalin is a sodium blocker. And when we do that, in about half of these patients, we have on-off appearance of that. So we may imagine that with ajmalin and with isoproterenol, we have a mean to reinduce this ectopy in patients susceptible to have that. So this is the first step, provocative maneuvers to identify the patient. All the slides will be available in the. And there is a second thing that is important too. In some patients with sudden cardiac death, we found nothing. MRI, etc., pharmacological tests. When you do some pacing close to the Purkinje, we have a 5 young lady who died and were resuscitated, where we can produce a repetitive polymorphic VT preceded by that. We can induce something that looks like a Purkinje reentry, and this is something in normal people, we don't have. So we start to see some new method that can identify this patient and maybe anticipate if you have a patient with unexplained syncope, maybe we will identify that. So this is the beginning of something that will progress. Quinidine is the best treatment because we suppose the ITO current is one of the main elements explaining the starting of the Purkinje activity. Triggered is very efficient. When we know where is about the focus, because we suppose that some of this focus can turn around, we ablate, and this is the key of the success in ablation. We also expand application around. We said prune the tree. It's starting from here, but maybe the other one will participate, then we turn the tree. It's very distal. We do not impact on his Purkinje and on the ECG. And with 9 minutes per PV site, we have a success rate that is demonstrated in these 2 studies. 5 years follow-up in this patient. I remember this patient I did in Germany, single PVC, 3-minute RF in May 2000, and nothing in 22 years. So all the disease were in the tiny spot. The follow-up in the group of this patient, 86% success, no more shock. And I told you that this idiopathic VF looks very like ischemic Purkinje activity. In this work we did with a group in Japan, 110 patients, 92 are successfully treated. So we have high success rate in this patient if quinidine that you can choose doesn't work. Now, VF in structural disease, post-infarct, cardiomyopathy. This is the main message. What is happening in the first second at the VF onset, what is happening here will determine if VF will continue, the patient will die, or if VF will stop, he will have a syncope. This is it's like a coagulation that is preceded by aggregation. What is happening in the first second is crucial for the rest. Trigger and substrate in structural disease are mixed. They are in the same region. So this is a good point. You ablate the substrate, you will kill at the same time the trigger. And what is new is the Purkinje network is involved, I will come that, and the VF ablation can be done in the same way and success rate than VT. VF is not a forbidden domain. It can be accessible to ablation. This is a work we did in Bordeaux, and this is the work done here with Sanjeev, Paul Wang, and David Krumen. Sanjeev has used a basket catheter to identify the rotor, I mean the drivers, and we have used body surface mapping to see a panoramic view and see when we induce VF, where was the main source. So we are here in the heart. We induce VF, and we have many activity, but we see one spot here where we have a cluster of activity, a second one cluster. And so we determine 2 or 3 clusters, and we consider they are the main source of VF, and we consider that it was what we are looking for. Because in contrast to what was described initially, it's not evenly distributed, we have a cluster. And the cluster, of course, have something to do with the mechanism. This is the initial second of VF. And we didn't find it. It's already published many times in animals. This is the initiation 0. Then we have 2 seconds here, 4 seconds. The initial 4 seconds are where VF accelerates the most. If you have 20 minutes, it's going this way, and then it will slow down. So this is really a phenomenon, a restitution or something like that, that looks to be crucial. That I'm not expert on that, but there is something that we have to look for, maybe in terms of prevention. We have a patient in whom we induce a VF that spontaneously terminate. We induce VF and it stops in 6, 10 seconds, sometimes 20 seconds. And the same patient in another induction will have a VF that will continue, and we have to cardiovert. This one will have a syncope, this one will die. And the difference is clearly in the initial slope. When it starts, it's very quick, then there is a plateau. It doesn't speed up, it will stop. When the curve is going steadily down, accelerating, it will continue. Maybe there is a domain here. If we can prevent this restitution shortening, that can be of interest. If you have a beta blocker that can do that, maybe the patient will be protected for different things, plus in case of. The first thing, the driver, I mean the main source in this room, are closely related to the scar. That means every time you have a scar, an island of fibrosis in the heart for cardiomyopathy or something, is where the re-entry will start. The substrate is the origin of that. It's not inside. Usually it's close to that. It's that anchoring. It's like in a river. You have a river where you have a stone, and you will see close to the stone this re-entry. This is ischemic cardiomyopathy. Donc, in 80% of ischemic cardiomyopathy dilated, 80% of the drivers are adjacent to the region of scar. This is a cardiomyopathy. In this patient, we have a 12 rotation here. And when we look at the electrograms here, we see abnormal electrograms. We can use imaging, late enhancement. We can use signals, because some patients may have a normal MRI, but the signals will tell you that there is a microstructural abnormality that indicate. You see here a signal lasting 100 milliseconds instead of 30. So this spot is abnormal. Brugada syndrome, the driver are there, and this is in the work by Sanjeev and the group here, where there is a close relationship between the driver ablated here and the scar. Now, a second point, the drivers are close to the scar region. This is what we see. If we want to make a movie of what is happening in humans, it starts from here, a trigger. The trigger is close to the substrate. It starts here. Then there will be some re-entry adjacent to this one. It will be what we call organized VF. And then it's going quicker and quicker, and then spreading everywhere, and you get disorganized and irreversible VF. Is the way we see how this happening. When we do ECGI here, we can see the cluster of activity. When VF become, the patient is dying, it's everywhere, it's probably three-dimensional, and we cannot see clearly some cluster like that. The second thing is, in addition to the scar-related reentry, the Purkinje, again, this small tissue was involved. And this is an interesting finding, because again, we have a second tissue more accessible to ablation. In dilated cardiomyopathy, hypertrophic cardiomyopathy, when we induce VF, in 1/3 of them, we have the Purkinje, which is the driver. It's not the myocardium, it's a Purkinje. And when we look at the tracing, out of the 5 seconds of VF we have mapped, 3 seconds, that is a lot. A lot of this activity is launching from the Purkinje. And when you consider the trigger, the Purkinje, or the driver, we can state that about half of VF in ischemic cardiomyopathy and non-ischemic are associated with Purkinje. That means when you do some score in terms of prediction of death, we can do a score based on myocardium, but we miss this element because it's hard to say how can we evaluate the Purkinje, at least right now. This man, 29 years, he has a typical ECG of cardiomyopathy, hypertrophic. The septum is thick, 27 millimeter. He had a 7 VF on ICD, no ectopy. We induce VF. If you said, okay, this is VF, but if you have a catheter at the right place in the Purkinje, look at 1, 2, 3, 4, 5, 9. These 9 bits are driven on the Purkinje, and then it explodes everywhere. Another man, 63 years, 5 VF, looks all this long initial episode of induced VF is also linked by Purkinje. That means the phenomenon is, it starts by a trigger, but everything launching the process will be in the Purkinje before it disseminates. Now, ablation. Donc, we have ablated 42 patients. The trigger, when we have it, is involved. Donc, we will ablate the triggers. We will ablate the Purkinje where it's involved. Both are linked to the substrate, and we will ablate the substrate. Donc, we have a different recipe depending on what you find. We don't say I will ablate one. Everything is mixed, intertwined. Donc, the success are here. Before ablation, we had a 32 months of pre-procedural from sudden death to ablation. After, we have 56 months, much longer. Before ablation, they had 7 VF, as median 7, mean 10, and after the median was 0, and the mean 1.5. It's clearly successful, even if we have, I think, 30% who had still recurrences, so more after. But anyway, we have clearly a benefit of that. And of course, we have not re-ablated some of these patients. So the method can achieve results similar to what we have in VT and is clearly improvable. Now, the last things is this VF is structurally normal heart or idiopathic mean unexplained. In the young, is 10% of all sudden cardiac deaths. In Southeast Asia, this is a bigger problem. In this 1 million population, they have much more patients with structurally normal heart or idiopathic VF probably for genetic reason. There is a lot of different syndromes that we have to decipher. We know Brugada, early, Wipo, longitude, etc. But when we do the phenotyping, we guess there was something. I told you about this 5 lady where VF was inducible in the Purkinje. For sure, they have something special. They have a genetic somewhere that we have not identified. But this is interesting. We have different subsets. When we will have 20, we will have all the game to then to move in prediction. Spectrum associated with the genetic mutation. For the clinical practice, the diagnosis requires not simply ECG, Holter, and MRI, but we have to do examination to find all these different subsets. It is sure that the main mechanisms are abnormal propagation, I mean conduction. When you have something, this type of signals, that means your microstructure in the myocardial is abnormal. Donc we said synonyms, conduction, propagation, or microstructural alteration is about the same. We have abnormal focus, we have normal structure, but abnormal ion channel repolarization. In the simple situation of a structurally normal heart, we suppose that all these three mechanisms can appear in isolation. All the different scenarios happen here. When you have a patient with a big infarct, taking medication, autonomic nervous system, etc., it's too complex to decipher what is here. Now we have simple situation. It's what the discussion with Sanjeev yesterday. It will be a Rosetta Stone. I mean, it will be simpler. Maybe we will have some key to understand. This is what we do in a patient with cardiac arrest. Suspicious syncope, complex PVC. We do structural imaging. We record all the extrasystole. I mean, in a context of sudden death, it's trivial to say that, but each extrasystole probably has a link with the substrate. But we have nurses that do all this work. We have two nurses. All patients have a setup of different pharmacological tests to capture each single event in 12 lead or in body surface mapping. We can do more, but these very simple tests that you can do in half a day, MRI, etc., plus exploration of extrasystole are done to all these patients with apparently a normal heart. This is a simple classification of this spectrum of VF without structural heart disease. Conduction abnormality or microstructural abnormality is a Brugada syndrome. The Brugada syndrome is not repolarization. It's an abnormal depolarization that conducts to the ST wave, but is clearly something that is wrong in the structure of the heart. We will see some J wave are also due to the same abnormal conduction and some idiopathic VF. What is interesting is most of these conduction abnormality in VF and normal heart are epicardial. They are on the external part of the heart, and because possibly they are not transmural, it's possible that they will be below the resolution of MRI because they are not thick enough. You have the fat tissue here, that is complex to differentiate. We can ablate this patient by doing ablation injection. Now we have repolarization abnormalities that you know, long QT, short QT, early VPO, where we don't do some ablation, but we have something to see with medication to block the abnormal channel. And we can also say the third mechanism is abnormal excitation. There is a focus somewhere in some idiopathic, in catecholaminergic polymorphic VT. Commotion cordis can be seen as something that is a bump, and then it starts and kills the patient. This is now a Brugada. In this Brugada patient that you diagnose by this ST elevation in V1, V2, the abnormality is here. You see abnormal electrograms here. If we do a biopsy at this spot of signals, you will see abnormal histology, fibrotic fat substrate. And if you are familiar with the inferior lateral J wave that you see here, or that you see here, that is for the same ECG phenotype, you may have two opposite mechanisms. It is where the electrophysiologic, the deep phenotyping can be helpful. For these two patients, one had abnormal substrate and histology in the inferior part. This one has abnormal structural condition, but he had something abnormal in terms of ITO or some repolarization channel. Deep phenotyping is also the key to work with genetic. Thanks to Nademani in Thailand, epicardial substrate is a key. So instead of going inside the heart, it's better to go from the external part and ablate the abnormal electrograms. You ablate the abnormal electrograms, and if you have some doubt if it's the substrate or not, the patient with normalized ECG, the ST wave will disappear. It will be normalized with provocation test. It will prevent VF inducibility. Donc, everything is there on this island of abnormal electrograms. And the risk has been published in Circulation a few months ago. Hemopericardium recurrent, the recurrence is 20% that we have to reablate. When it is appropriate to propose ablation, it is very logical. A patient who had recurrent VF on ICD is the best indication for catheter ablation. And in some of patients, because of the job, we can do ablation early because they have pilots in a plane, etc., for professional reason. Now I finish by unexplained ventricular fibrillation. This is Ackerman in US for athlete. This is Kim in Korea. You see here different cause of sudden death, unexplained. Nobody like unexplained. And you see that sudden unexplained death is 1/3 of all this group of patients in the young athlete. In Korea, it's 37%. Donc, it's a big cause of sudden death in the young. It's the most frequent. The other one are what we have discussed, long QT, etc. This is the last frontier. It's likely that when we see a phenotype, we are here, or brugada, infarct, what we want, dysplasia, but probably I think most of them are the same, except that they are below the resolution, because we find the same type of signal for information. They are just below the microscope. We have done a work on 51 unexplained sudden cardiac deaths. They are 29 years. They all survive an episode. MRI, repolarization, pharma test, endo-epi mapping has been performed. You see these two tracing. It happened in a beach, 19 years. He was sleeping, and he was resuscitated thanks to his wife. Donc, a lot of these idiopathic VF happen at rest or during sleeping. We found subclinical myocardial abnormality, microstructural abnormality in most of them. This is a man here. We have an island of abnormal electrograms. MRI is normal, and we have some abnormal potential. The microstructure here is abnormal, and we don't know why. Is it a subclinic form first of dysplasia, of cardiomyopathy, the COVID post, I don't know. But it's similar. This is something of that. We have not done many biopsy on that, but we have to look for. But the result is you have a lesion somewhere, you have a risk of dying if the structure of the lesion is able to generate VF. And it's small. So this is 5% of the surface, it's enough to kill you. And the other big group is Purkinjeopathy. So we have microstructural cardiomyopathy, and we have some Purkinje abnormality. We have seen that. All these young patients who die, it's unexplained, but we have sometimes for a few hours this ectopy. And this is a case of microstructural. This lady is 33 years. She was walking in the street, sudden death, resuscitated. And look at that. This is the late potential. It's high amplification. There is absolutely nothing here. It's a very nice QRS shape. And when we map on the epicardium, we have two islands with abnormal electrograms. Something is wrong here, something is wrong here. And our experience of unexplained sudden cardiac death, most have abnormal electrograms, most is epicardial, it's not transmural, and the surface is 14 centimeters square, 5% of the total. This is explanation to the sudden cardiac death. For some of them, we have done cardio insight, but we induce VF, and the VF doesn't spread everywhere. There is a cluster somewhere, and when we go to the cluster, we found this potential. Donc, we have a link with the physiopathology. And I will finish by also case we are doing in Bordeaux. In the Liryc, we have the right to work on a patient who died. We donate or post-transplantation. So we get these two hearts. We have many hearts. We have 70 or something like that. Pierre died 2 weeks after from brain damage after a game, rugby or something like that. This is a tracing when he was in post-ischemic intensive care. This is a heart. So we can get the heart exactly like in transplantation domain, and we can put the heart inside the Langendorf, and for 8 hours, the heart live again, and we can do a lot of high-resolution mapping, histology. We have an MRI of 9.4 Tesla. So we can really do in experimental condition, we can do some molecular. So the heart is here, and this is exactly the optical mapping corresponding to this pattern. So no fat tissue. So we know that optical mapping from here will be nice. And this is what we see. The patient is in sinus by pacing. And we have here, the red one here, we have this island of abnormal conduction. Everything was here. We did some pacing in this heart. And by pacing, we prolong conduction, and we have some reentry. He died because he has this cause. If we have done an autopsy, we cannot find it. It's too subtle, it's too microstructural. And he had the SCN5A mutation, and his mother too. This is Emina. Emina had early repolarization, transplanted. And the disease in the left ventricle was here, 2 islands of abnormal early repolarization. This is a microelectrode here on the left, and we have this notch here. And we also are identifying the mutation. But this is a perfect setup. This is a translational patient between molecular and that. And they corroborate what we have found in clinics. In conclusion, we have a fibrillating heart. It's the most complex phenomenon in terms of arrhythmia, but they derive from discrete source of area. So this is a good point. It's not spreading, they start from there. And if you can look at the starting point to ablate or to predict the patient, this will be the future, I think. AFib, pulmonary vein, left atrial area, VF, Purkinje network, individual. The catheter ablation, because this was the subject, is effective. We are developing ablation tools thanks to the industry that will optimize the success. But all this effort of screening and of deciphering the substrate are done to improve the program of prevention, which is particularly insufficient to predict patients with sudden cardiac death. Thank you.